So thank you everyone for joining us. 5 minutes and we're gonna start the event. For those who recently joined, 3 minutes and we will start. One more minute and we will start, inshallah. Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum everyone. Good evening, good morning, doctors and colleagues who are virtually connected. We are delightfully welcome you all to our first IVPN Oncology Educational Series in 2022, through which we will share the latest updated evidence-based oncology practice, learn from our oncology professional experts, and aspire our daily pharmacy practice. Our event today, we're gonna focus about the pain management in cancer patients and the role of the oncology pharmacist. We have grant you the access to submit your questions in the Q&A sessions, And at the end of the presentation, we will share these questions with our speaker. And in case we missed any, don't worry, we will share them with the speaker and we'll get back to you with the email you registered through this event. As well, we will be share this recorded presentation on the IVPN library, and we will share with you when it's gonna be uploaded so that you can be easily attended at your ease. And now, with no further delay, I would like to introduce our speaker for this educational event, Dr. Maha Wazni. Dr. Wazni received her bachelor degree in pharmacy from Lebanese American University in 2011. And then in 2017, she completed her master degree in clinical pharmacy from the Lebanese University. Dr. Wazni has worked as inpatient and outpatient hematology-oncology pharmacist at the American University of Beirut Medical Center for around 10 years. She has been also a part of the palliative care team program of the multidisciplinary team in UBMC. Ms. Wazni has given a variety of oral presentation to nurses and pharmacists as local and national level in Lebanon. Recently, she moved to Doha as a senior clinical pharmacist at Amman Hospital. She has been certified from Harvard Medical School in immuno-oncology and cancer genomics. She is an active member in the Order of Pharmacists in Lebanon. Her professional interests include medication safety, palliative care, and research. Dr. Wazni, we are so honored to have you with us. The mic and the floor is yours.
Thank you, Dr. Ismail, for the presentation. I would like to thank everybody attending this session, including the panelists and the attendees. I would be talking about today about an important topic in cancer patients that is not really always targeted, which is cancer and breakthrough pain in cancer patients. So let's start my presentation. Just to make sure the slides are shared well. Okay. So I declare to the meeting attendees that there are no financial relationships with any for-profit companies that are directly or indirectly related to the subject of my presentation. At the end of the presentations, the participants will be able to identify the causes of cancer pain, to know the general management of cancer pain according to ESMO guidelines, define breakthrough cancer pain and advise on the proper management of breakthrough cancer pain, manage the side effects of opioids, identify the proper management of resistant neuropathic pain, outline the clinical pharmacist role in managing cancer pain. Let's have just a brief description of the prevalence of pain in cancer patients. More than 50% of cancer patients experience pain, and around 70 to 80% of the patients are with advanced disease, suffer from moderate to severe pain. 67% of patients have their pain unresolved, unfortunately, and 43% use strong opioids to treat cancer pain. Why pain is an important topic to talk about and to resolve in cancer patients? Because it effectively affects the life and the quality of life and the functional life of patients. Pain duration and pain severity correlate with the risk of developing depression. And most cancer patients are disabled on an average of 12 to 20 days per month, with 28 to 55% unable to go to work. And untreated pain also leads to unnecessary hospital admissions and visits to emergency departments. So what are the pain prognostic scores? a number of pain-related factors and pain-related in response to the pain treatments. There are high baseline pain intensity, neuropathic pain, and incident pain that are more difficult to treat. Patient characteristics include a personal or family history of the following, which include illicit drug use, alcoholism, smoking. Mental health issues such as depression or anxiety and cognitive dysfunction are main factors that may affect the prognosis of pain management, and will help personalize cancer pain management when identifying each patient factors. There are different scores that are used for pain assessment, and the most frequently used are the visual analog score scales, the verbal rating scales, the numerical rating scales. So the visual analog scale, as seen, it is to ask the patient to mark a place on the scale that matches the level of pain from 1 to 10. While the numerical scale also, it is to use a number to rate the pain also from 1 to 10, with 1 to 3 as mild, 0 as none, 4 to 6 as moderate, and 7 to 10 as severe. According to WHO analgesic ladder, it divided the pain into 3 categories. Mild pain, which is included a NRS of less than 3 out of 10, and the analgesic of choice usually is paracetamol or NSAIDs. Mild to moderate, it is 3 to 6 out of 10, and to use weak opioids plus or minus paracetamol or NSAIDs. And the third, which is moderate to severe, which is NRS score of more than 6 to 10, to use strong opioids plus minus paracetamols or NSAID. So, however, according to the ESMO general guidelines for the treatment of cancer pain, also, they took into consideration the WHO ladder treatment or appropriate analgesia management, and they added that patients should be informed about their pain management and should take an active role in their pain management, and that the drug of choice should be the most favorable route is the oral route versus the IV or the sub-Q. Analgesics also should be given around the clock with breakthrough dose. Analgesic techniques should also incorporate different procedures, including anti-tumor treatments, interventional analgesic therapy, non-invasive techniques such as psychological and rehabilitative interventions. And in some cancers, radiation is part of the interventional therapies that should be done. Some authors have also suggested eliminating the second step of the WHO ladder, with weak opioids being replaced with low doses of strong opioids. So the opioid of choice for moderate to severe cancer pain is oral morphine per ESMO guidelines. The characteristics of oral opioids is the onset is 20 to 30 minutes. They peak in 60 to 90 minutes, and duration of effects 3 to 6 hours. And the transmucosal fentanyl formulation, the oral, buccal, and sublingual and intranasal have also shown beneficial effect in the rapid onset because of the rapid onset and short duration in breakthrough cancer pain, and I will discuss this in the coming slides. There are indications for standard normal release of opioids, also morphine and oxycodone, in breakthrough cancer pain too. So this is just a revision of the relative potency of opioids compared to morphine. As we see, fentanyl, buprenorphine, methadone, hydromorphone, oxycodone are much more potent, and then comes morphine, and then pethidine. So this is just just a fast review of the relative potency of opioids to morphine. Now let us move to our topic today, which is the breakthrough cancer pain. What is the breakthrough cancer pain? it was described as a transient exacerbation of pain that occurs either spontaneously or in relation to specific predictable or unpredictable trigger, relatively stable and adequately controlled background pain, not necessarily treated with opioids. This is according to the EAPC in 2012. However, the current BTCP, the breakthrough cancer pain definition, is considered as an episode of severe pain that occurs in patients receiving a stable opioid regimen for persistent pain sufficient to provide at least mild sustained analgesia. This is according to the ESMO guidelines in 2018. So as described, the time to peak of a breakthrough pain is 3 to 5 minutes. It is mostly moderate in nature, and the duration of episode is 15 to 30 minutes, and number of episodes may go from 1 up to 5. So what about the prevalence of BTCP in cancer patients? The overall pooled prevalence was around 59.2%, with high heterogeneity ranging between 39% in outpatient clinics and 80.5% in hospice centers. More than 1 in 2 patients with cancer pain experience BTCP. So also in pediatrics, it was also noted. It's not only in adults. So there are, for this reason, there are different guidance toward the diagnosis and assessment. I will pass quickly over them. We have the Davis algorithm, the breakthrough pain assessment tool, the Alberta breakthrough pain assessment tool, Italian questionnaire for intense episodic pain, breakthrough pain questionnaire for children. So there are different algorithms that have been worked upon in order to analyze and diagnose and assess the patient well to know what is the best management for breakthrough cancer pain. So to go over Davis algorithm, we usually ask the patient, do you usually have pain? It's either no or yes. If the patient does not have pain, then the patient does not present for breakthrough pain. If yes, is your pain controlled? If no, the patient does not present for breakthrough pain, definitely. If yes, if he has a transient crisis, the patient does not present no. If he has yes, then the patient will present for breakthrough pain. So what about the BAT, which is the breakthrough pain assessment? It is also like a questionnaire from 1 to 10. The patient has to answer and score from 1 to 10 different questions, including how much does the breakthrough pain distress you, how much does the breakthrough pain stop you from living a normal life. So how does the pain affect, or the breakthrough pain affect his quality of life and function. Also, the Alberta Breakthrough Pain Assessment is also multiple questions in order to assess different to assess the severity and the frequency of pain. So why it is important to treat the breakthrough pain? Because breakthrough pain increases anxiety, increases depression, and increases also the healthcare visits. It will also affect the social relationships and sleep. It reduces also the quality of life and the patient satisfaction with treatment. So it's really an important aspect to control breakthrough pain. And there are different challenges that we encounter as healthcare professionals, and especially in palliative care teams, in patients suffering from breakthrough pain, because the pain is heterogeneous in nature, and it may be categorized as somatic, visceral, or neuropathic. So it's very important to categorize the right and diagnose the patient right. There is no universally accepted definition of breakthrough cancer pain till today available. There is a deficit in knowledge of healthcare professionals regarding the breakthrough cancer pain treatment. And it varies between individuals and within a given individual over time. So it's really hard to identify. And there is a lack of validated tool for the diagnosis of BTCP. Although I mentioned different tools, however, which is the right tool will be really challenging for choosing for a specific patient. So as pharmacists, we care for the characteristic of an ideal treatment for breakthrough cancer pain. So it's very important to choose the right medication. And as we notice, if we use a slow onset of action agent, it will have a high systemic exposure, and the majority of the breakthrough cancer pain will not be controlled with a slow onset of action medication. And if we use a long-acting or long-duration medication with rapid onset, it may may decrease the pain. However, it will lead to systemic exposure in the body and will lead to accumulation in the body. So as pharmacists, we recognize that the best medication is that with a rapid onset of action and a short duration of action. We need to have this combination. So to go over different agents available to treat breakthrough cancer pain and cancer pain in general, as I mentioned, according to the WHO ladder, we have the morphine, we have the oxycodone and fentanyl, and checking their liposolubility, we have the fentanyl with the highest liposolubility. We have also mostly they are all metabolized by the liver. We have morphine also in the urine. It is excreted in the urine. As for the oral bioavailability, we noticed that fentanyl transmucosal have the highest oral bioavailability of 65 to 70% compared to oxycodone, which is 60%, and 25 to 30% for morphine. And as we notice that some of the advantages of morphine are because it's available in different dosage form. It is safe to, in case of liver failure, as I said, it can be excreted by the kidney. Oxycodone, it is safe in elderly. It has weak metabolites and available in multiple dosage form. However, when we go to fentanyl transmucosal, it is also safe in case of liver and renal failure. Relatively, it has the fastest onset of analgesia, so it might be the drug of choice for breakthrough cancer pain, as I mentioned earlier, and it doesn't have an active metabolite. So to discuss further the transmucosal fentanyl formulations, we have the buccal tab, the buccal tab, the sublingual, and the intranasal. And as we noticed, the fastest onset of action will be for the intranasal and the sublingual tab with 10 minutes and 15 minutes for the buccal tab. And the highest bioavailability is for the buccal tab. And they have minimal limitations, including mucositis. That's mainly, so they are relatively safe and friendly to use in case of needed in breakthrough cancer pain. So as we see, fentanyl has different formulation. It started with IV, then the transdermal patch, the oral transmucosal lozenge, the buccal tablet, the buccal solubility, and sublingual tab, and finally, the sublingual fentanyl citrate that was developed to help overcome the issues associated with conventional oral opioids relating to the onset and duration of action. And following the administration into the oral cavity, it disintegrates into ordered units, and these units stick to the oral mucosa through the bioadhesive particles, and then dissolution happens of the carrier particles accompanied with the dissolution of the active drug, it is rapidly absorbed across the oral mucosa into the systemic circulation. So the dosage and administration, it is available in different dosages ranging from 100 micra to 600, 200, 300, and 400 and 600 micra. To administer SLF, one tablet is placed under the tongue at the deepest part where it is allowed to dissolve completely. The tablet should not be chewed, sucked, or swallowed. So we need to know that fentanyl, the SLF should be also titrated according to the regimen. And no more than 2 tablets should be used at the same time. In one episode of BTCP, patients may receive no more than 4. And patients should wait at least 2 hours. So what are the main side effects of opioids? We have the nausea, the vomiting, the constipation, pruritus, confusion. So mainly most of our patients on opioids will suffer from constipation, and we have to make sure to monitor well for side effects and manage accordingly according to the side effects that each patient would have. So we can reduce the opioid dose to decrease the refractory side effects, or we can use a co-analgesic. Continued use of antiemetics, for nausea, laxatives for constipation, major tranquilizers for confusion, and psychostimulants for drowsiness. We can switch to another opioid agonist or another route that may allow titration to adequate analgesia without the same disabling CNS effects. And we can use naloxone, which is a short-acting opioid antagonist for IV use, able to reverse symptoms of accidental severe opioid overdose. I have mentioned earlier that interventional therapies, in addition to medications, are needed in order to do the proper pain management. This may be, and radiotherapy may be part, may be part of the management and has efficacy in providing pain relief caused by bone metastasis specifically. And it has a role in tumors compressing nerve structures and cerebral metastasis. Some patients, as mentioned earlier, will have breakthrough cancer pain or cancer pain that is more of resistant and neuropathic in nature. And for this reason, we have to make proper diagnosis for each case. And it may be caused by tumor infiltration or due to paraneoplastic or treatment-induced polyneuropathy that might not be controlled by opioids alone. So this will lead to, may cause psychological problems in different patients. And the best options for addressing neuropathic pain is the tricyclic antidepressants and anticonvulsants, including pregabalin, gabapentin, and carbamazepine. In cancer patients with a neuropathic pain, non-opioid and opioid analgesic may be combined with TCAs, tricyclic antidepressant drugs, or anticonvulsants. And steroids should be considered in case of nerve compression. As a pharmacist, where do we stand? So as a clinical pharmacist, we have the part of medication history review and reconciliation. And in addition to that, we have to recommend for initiation, modification, or discontinuation of medication regimen. And this is very important if you have a palliative care program or multidisciplinary team or committee in your setting. As a palliative care pharmacist, this is one of the main roles in adjusting the medication schedule and recommendation for initiation or adjusting the dose for better management of pain. We have to also assess the adherence to medications. We have also to make sure of the behavior modification techniques and follow-up services for non-adherence. We have also to make sure of that all his medications, all the patient's medications are under clinical monitoring and in the appropriate pharmacokinetic level. We have also to educate patients regarding self-administration and monitoring of medications, and also to report side effects, monitor for the therapeutic effects, drug interactions, adverse events through drug regimen review. In addition, we need to check the laboratory data of the patient and ask the patient for any side effects, as I mentioned earlier. We have also to identify and monitor for behaviors of medication misuse, abuse, or addiction, especially for patients who are on chronic use of opioid. And we have also to facilitate communication between care team members and the pharmacy. We have also a role in implementing strategies for opioid overdose prevention, including access to naloxone, assisted with the development of clinical protocols to encourage the systemic approach and to use various analgesic therapies, conduct academic detailing and or use evaluations, assist with quality improvement projects to improve processes related to patient care in this field. So this is mainly the role of mainly the oncology pharmacist or pharmacist involved in palliative care or palliative care program. So I'm going to conclude the presentation with the key takeaways. Analgesics for chronic cancer pain should be given around the clock with breakthrough dose. BTCP is an episode of severe pain that occurs in cancer patients receiving a stable opioid regimen. Rapid onset and short duration of action are the characteristics of an ideal treatment of BTCP. Clinical pharmacists play an important role through multidisciplinary approach in pain management and monitoring. Thank you. So I open the floor for questions. Fatima, can you hear me?
Yes, Dr. Wazni, thank you so much for your comprehensive presentation.
Thank you.
Thank you so much, Dr. Wazni, for your comprehensive presentation. We actually really enjoyed it. Prior to going to the Q&A session, Dr. Wazni had wanted to test your knowledge post her presentation. So we're gonna start with a poll session in which you're gonna vote anonymously, and we're gonna discuss these questions. So we started the poll question. The first question, as you see on your screen, according to WHO ladder, the proper management of moderate to severe pain is paracetamol, NSAIDs, weak opioids plus or minus paracetamol or NSAIDs, strong opioids plus or minus paracetamol or NSAIDs, or weak opioids. So we have the second question. According to WHO ladder, the proper management of mild moderate pain is paracetamol, NSAIDs, weak opioids plus or minus paracetamol or NSAIDs, strong opioids plus or minus paracetamol or NSAIDs, or weak opioids. The third question is, the drug with the highest oral bioavailability is morphine, oxycodone, fentanyl transmucosal, or fentanyl transdermal. So we're gonna give you 30 seconds more to submit your answers, and then we're gonna see your answer, and Dr. Wazni will comment on it. Wait, so 10 more seconds. If you haven't yet submitted your answers, please do so. Great. So the results are, Dr. Wazni, for question number 1, according to WHO ladder, the proper management of moderate to severe pain is, we had actually 50% of the audience answered strong opioids plus or minus paracetamol or NSAIDs. So is
Yes,
it correct?
definitely. Yes, definitely. The treatment of choice for moderate to severe pain is strong opioids plus minus paracetamol or NSAIDs, as mentioned in the slide containing the WHO ladder. The WHO ladder categorization of pain and the proper management. Let's see the second question.
Yeah. So the second question is, what is the proper management for mild to moderate pain? And we had 62% submitted weak opioids plus or minus paracetamol or NSAIDs.
Yes, definitely. So it is the right answer. We will use weak opioids plus minus paracetamol or NSAIDs. Although the ESMO mentioned that we can cancel this step and just go for the strong opioids.
Okay, great. So the third and last question, the drug with highest oral bioavailability is, so we had 60%
Perfect.
voted fentanyl transmucosal.
So this is the right answer. Well
Great.
done.
Excellent. Great. Thank you so much.
Thank you.
So now we will go to the Q&A section. We have some couple of questions. We have Dr. Muhammad Abdel Raouf asked, can we initiate fentanyl transdermal patch for opioid naive patients?
Patches can be used in cancer patients, definitely. However, they would be in at later after trying the oral route. As I mentioned, that the oral route is the first line of morphine oral route is the first line of the treatment for patients, and it's the preferable route to start with. In case later in the disease progression and there is no good oral route, or the patient is suffering from nausea, vomiting, and others, and for the patient preference, we can substitute for patches according to the severity, definitely, and the patient's frequency of pain. So this is it.
Great. So we have another question, but actually it's from anonymous attendee. What about the role of tramadol for cancer patients?
Yes, tramadol can be used, but however, we would like to follow the general guidelines by the WHO and the ESMO regarding the use of NSAIDs and paracetamol in early stages. In mild to moderate, we'll use the weak opioids, and in severe pain, we would use the strong opioids. Tramadol will be an add-on medication according to the patient, and we would not like to use it for prolonged periods, and especially in elderly patients. So it's not like a drug of choice at the meantime.
Okay, I have a question from Zaina. What is the average relative potency of oral to IV morphine?
So the average IV to oral, as you mentioned.
Sorry, oral to IV.
Oral to IV is...
Yes, what is the average relative potency of oral to IV morphine?
It is it's almost between 1 to 2 and 1 to 3. This is the usual.
So we have a question from Noor. She's saying, which opioid is suitable for epileptic cancer patients?
So we need really to look at the patient, what is the type of epilepsy, and there are two different diagnoses. We need to identify different, like the diagnosis of epilepsy depending on which type of epilepsy she has, and what is the severity of pain. So it's kind of a bit general question to answer on. So we have to look on the frequency of pain. And also we have to look on the type of epilepsy the patient has, if it is controlled or not, and to make sure that we are monitoring the medications properly and the interactions with the anti-epilepsy protocol being used to prevent any accumulation of the medications used and the side effects. I cannot hear you, Fatima. You are muted.
Yes, sorry, I had some problems. So we have another question. It is, what is the safest opioid in kidney failure?
Yes, in the presence of renal impairment, all opioids should be used with caution and at reduced doses and frequency. And it is shown that buprenorphine is the safest opioid and it is the safest option in patients with category 4 or stage 4 or 5 renal impairment for a GFR less than 30 ml per minute. So most of the opioids are not really not really safe. We have to check each one's guidelines, but the safest is buprenorphine for a GFR less than 30 milliliter per minute.
Great. So we have a question from Nakhil, I think. So what are the non-pharmacological supportive pain management strategies in cancer patients?
Yes. Yes, this is a very important question. As I mentioned earlier, pain sometimes may be psychological. We have to support the patient in every way possible. We have to make sure that all the psychological and social factors around the patients are going well. And we have to support his family as well. And I think non-pharmacological management would be having a good sleep, eating well. We have to make sure that his symptoms of the disease are being also controlled in terms of nausea, vomiting, any kind of other symptoms that may be accompanying that pain due to the side effects of the treatment or the tumor itself, or anything that may affect his function at home or at work.
Great. So we are having a lot of questions. So we have a question is, okay, 1 second. Okay, how do we manage breakout through cancer pain?
Breakthrough cancer pain, they mean?
Yes, yes.
So as I mentioned in the slides, the breakthrough cancer pain need to be treated with a medication with rapid onset and short duration of action. And with a comparative analysis I've shown in the slides, we noticed that transmucosal fentanyl treatments are the best that targets the needed agent as short duration and short onset of action. So they are the treatment of choice. But however, we can use oxycodone and we can use morphine definitely, depending on the patient's factors.
Okay. We have also a question: if the patient cannot swallow any oral medications, is there any routes other than the IV that we can give the patients?
Yes, we can use the fentanyl patches. We can use the rectal route in advanced palliative care patients, end-of-life patients. There are many data about other routes that can be used. We can use the IV, for example, if possible, if we can prick the patient. So it can be manageable.
Right. So as well, we have a question from Noor. She's asking how we can prevent opioid toxic dosing leading to respiratory distress.
Okay, so we have to make sure that the patient is taking the proper regimen, and we can reverse the opioid toxicity with naloxone according to the naloxone dosing, and we have to proper manage the patient in case overdosing happened.
Great. Thank you so much. Actually, we have a lot of comments that they are saying it was an excellent presentation, and
Thank you so much.
they learned a lot. And we actually had a question from Ala. She's saying, is it possible to get the slideshow? We're gonna discuss it with Dr. Wazni, and
yes.
we'll get back to you, Ala.
Okay.
So we have a question from Dr. Rihan. She's saying, is there a difference in pain assessment scale of children and adults, or if it's the same scale?
Okay, so I need to check this out if there is another scales that can be used specifically or preferred according to the literature in pediatrics. However, as I mentioned, the visual analog scale and the NRS are the main scales that are used in both adults and pediatrics. However, I would like to look further for any other reference that may target pain scale in pediatrics. That will be interesting.
Great. So Dr. Rihan, we will get back to you for your answer by Dr. Wazni, inshallah, soon. I think, okay, we have a question as well. How long it takes to develop a tolerance to a prescribed dose of opioids in cancer patients? Is there any data for that?
How long does it take? I also need to check this out. It's basically depending on the patients. Yes. I think depending on the dose and the duration also. So, and the patient's pain, frequency of opioid dosing. So we really need to look to the patient factors, the dose, the frequency, and the severity of the pain itself. And I would look also, I would check it out if there is a specific general time for developing tolerance as a general as for all opioids.
Opioids, yes, great. Thank you so much, Dr. Wazni.
Thank you.
We really appreciate your time, your attendance with us. Of course, we're gonna have you more with us to share your experience in this field. In this field, you have a huge experience.
Thank you so
we really
much.
appreciate your time.
Thank you so much, and I'm really looking forward. Thank you for all the attendees and the panelists as well.
Thank you, Dr. Wazni. So now, our dear colleagues, we reached to the end of the first IVPN Oncology Education Series in 2022. I want to thank Dr. Wazni for her time and for her participation with us. As well, I want to thank all our colleagues for attending our meeting. And last but not least, we want to thank Dr. Osama Tabbara, our leader and mentor, as well Dr. Abdel Dayam and the Oncology and Operation IVPN Oncology team for making this platform available to share our knowledge and experience. We will be waiting for you in Feb 20 for the second IVPN educational series, and it's gonna be about testicular cancer with our dear colleague, Dr. Rayo Rajan. We will be sharing the certificates of attendance within 2 to 3 weeks via email that you have registered through. And I want to thank you all for your trust in IVPN, and have a good day. Good night, everyone. Thank you so much for attending.